Hi everybody, Jessie here from Team IBS Dietitian. We have a live session today to talk about IBS triggers and some of the things that we see in clinic quite often these days, so you can be more aware of it. Okay, hi everybody, thank you for joining me. Drop it in the comments, tell me where are you joining from. Let me also write, we're going to talk about IBS triggers and also things we are seeing in clinic lately. Yeah, we actually are seeing some very interesting things in clinic lately. Hi, dietetic student. Oh my God, welcome. I'm so excited you're here. Let me see if Brooke has joined us. But some of the things we are, hi from India, from Mumbai. A lot of my good friends are from Mumbai. I live in Seattle, so we have a very diverse population here. Some of the interesting things I'm actually going to talk about, is fiber intake. Because right now in our clinic, we're seeing a lot of people eating a ton of fiber. And sometimes way too much causing them symptoms, even C or D. So we'll talk a little bit about that. But we'll focus on IBS triggers too. But taking too much or too little fiber can both be IBS triggers. Let me see. I think Brooke is here. How can I invite her? You're on. Can everybody hear me okay? I think so, right? I love it. Hi, Brooke. Oh, and
Hi.
hi. You've got a thing on your head.
I know. Oh, it's my computer.
Yeah, sometimes we are a little bit more tech challenged, but we try our best. But as long as you can hear us, hear the information we're talking about, I think that is a good start. Me also, sometimes I like to talk about poop, so I'll bring this next to me in case we talk about that. Maybe we can have a session that we just talk about poop as well. But IBS triggers, I think this is a very interesting topic that everybody wants to learn more about. Let's start maybe by defining what IBS triggers are. What is a trigger, right? Triggers are some things. It may not be food. It's something that you do or you eat, and it triggers some symptoms of IBS. In particular, we are with IBS, right? We're thinking about symptoms of bloating, symptoms of pain, cramping, constipation, or diarrhea. And a lot of people think that, oh my goodness, hold on one second. Brooke, will you continue? I'm
Yeah,
seeing 3 4th graders outside climbing a very steep hill. I'm gonna say something. I'll be right back. Sorry, guys.
that's life for you. Yeah, so
Hey guys.
any anything that can trigger your IBS would obviously be a trigger. Sometimes it's lack of sleep, sometimes it's something that will change your gut motility. It can obviously be a food, it can be stress. Really lots of different things can be triggers. So narrowing it down, journaling can all be ways to narrow it down. Journaling can certainly be a way to help pinpoint those triggers.
Yeah, absolutely. So it's not just food, right? And when we talk about lifestyle triggers, it sometimes could be meal timing, it could be hydration, it can be anxiety and stress. Those are things that you can create a plan that works for you to help know what your body respond to, and then have a long-term plan. But these are things people don't always think about. Now, what we are talking about today are for education only, and things that we are seeing. So this is not medical advice. We're not diagnosing you with IBS or telling you what to do precisely for your case with.
Oh, we just lost your audio.
Oh, can you hear me?
Yeah, now I can. Oh,
Back? Okay, I'm back.
you're back.
Yeah, I was gonna say, what we are talking about today is not medical advice that's specific to your case. Everybody with IBS is different, but here are some educations and informations to help you have better conversations with your healthcare provider, because IBS is different, right? Some people have constipation, some people have diarrhea, some people have both. What do you do? And with these educations, we hope, you can better understand your body. And oftentimes when people understand their triggers, they can avoid their triggers and prevent symptoms from happening. That's number one. And number two is understand, when symptoms happen, knowing that maybe they consumed their trigger, or maybe they did something differently. This is what caused them to have their symptoms. When you know what causes your symptom, I think this is what we hear a lot from our clients, is that my anxiety, that do I have a terminal illness, or do I have something else going on, which oftentimes happens to IBS patients, because most likely than not, you have done a lot of tests and everything came back negative and you were diagnosed with IBS. So it is a good thing to not have a positive test, but it does sound, it may make you feel like you're being written off by your provider, but no, that's how IBS is diagnosed, to rule out other conditions first. But anyways, and then when things are being ruled out, you're just left with IBS. And when you have constant symptoms or a lot of symptoms, that it causes a lot of anxiety. All right, so we've already talked about what we mean by triggers, right?
Yes.
Okay. Yeah. And the goal is to really understand your own individual triggers. Like we said earlier, everybody have different types of IBS. Everybody also have different types of triggers. Some people have food triggers. In those cases, you need to understand what food triggers you have. Some people have lifestyle triggers, and we kind of talked about this. I talked about this a little bit, is trying different things and figure out what works best for your body and make it your long-term plan moving forward. For example, meal timing is a good one. For example, for people with IBS constipation, a lot of the times, we really help patients or when patients create a morning routine that works for them, with hydration plan, with eating good breakfast, with protected potty time, then they have really way better bowel movements, so that it prevents the constipation from coming back or from building up. When constipation builds up, it can lead to a lot of stool burden, and the stool burden can lead to a lot of pain, discomfort, and what was that thing that we talked about? Gas. So, before we dive deep, and I want to talk about food triggers as well, because of course we're dietitians, right? Everybody follow us to learn more about food triggers, maybe low FODMAP, maybe something else. Let's talk more about food triggers. And before I go into talk more about food triggers, I want to also mention that we are currently enrolling our spring program. We have maybe 3 or 4 spots left for enrollment this January. So if you're interested in working with us, go watch our free IBS Masterclass to learn more about our approach, what we do with our clients, why this approach is different, and why it works, to better understand our approach. And then also at the end of the program, it also tells you a little bit of the program as well. I think the last 15 minutes is talking about the program, but the first 45 minutes is purely education, talking about IBS, different types of IBS, and different types of IBS diarrhea. We'll probably have to do another IG Live about different types of IBS diarrhea, because, even within IBS-D, there are different types. And if you don't know what type you have, you don't know what you're treating. So that's something we see very often in clinic as well. I think even right now we have, at least to my knowledge, one client that has overflow diarrhea that we sort of resolved by resolving constipation. Yeah, and she also actually has a food trigger as well that we identified along the way. And the next step for her is to do the FODMAP challenges to see what her tolerance levels are to different FODMAP groups. Now let's talk about food triggers. Where do we want to start? Do you want to count how many food triggers we looked at? I think there was like 9 that at some point. Let me actually pull it out and kind of.
Yeah.
I think the big one, of course, is the FODMAP triggers, right? Fermentable carbohydrates, that's one big one. And then another one that we see a lot in our clinic is non-celiac wheat sensitivity, which is, you know, gluten intolerance in another word. But this is a diet that we really do not love telling people to do because it's extremely restrictive. The low FODMAP diet, you can still eat FODMAPs and be okay if you eat certain amount of FODMAPs. The gluten-free diet is mostly gluten-free. It's not 100% gluten-free, but you have to cap it at less than 20 parts per million to not have symptoms. But that's something we see a lot in our clinic as well. But we don't just tell people to say, hey, let's try the gluten-free diet and see how you do, because most of the time, people might have tried gluten-free diet, but they're not doing it properly, so they're not getting symptom relief. That's the same as the low FODMAP diet. Some people came to our program thinking that they're doing the low FODMAP diet, they still have a lot of symptoms, or they did the low FODMAP diet, but their symptoms didn't get down to baseline. And when we do a diary or we look at their food diary or food journal, we see that they're actually not doing the gluten-free diet or the low FODMAP diet properly. And that's one of the reasons why symptoms don't resolve. But anyways, so FODMAPs, gluten, high-fat food or fried food, these are gut irritants as well. I mean, fat is harder to digest, but we don't want to remove all fats, right? But maybe potentially some of it. And when we talk about fat, we are also thinking about other conditions that, you know, may have overlaps with IBS, and that is bile acid malabsorption or exocrine pancreatic insufficiency. And we actually have clients who come to us with nonstop diarrhea that potentially, you know, have exocrine pancreatic insufficiency, and we worked on dosing her medication with her to help her better manage her diarrhea and slowly heal her guts. So again, you know, now I'm talking a little bit about diarrhea, and there's so many different types of IBS diarrheas out there. Okay, so I talked about FODMAP, gluten, fatty foods, caffeine, and alcohol. Again, these things, depending on what type of IBS you have, right? Coffee is fine if you have IBS constipation or if you have mild diarrhea. But if you have significant diarrhea, then the caffeine can trigger more diarrhea. Or if you drink a lot of coffee and that's overstimulating for you, it can affect your sleep, which is a non-food trigger. And it can cause you to maybe be, well, once your sleep is affected, then it affects everything else also in your body. I'm mostly thinking, you know, stress and anxiety level, and that can cause a negative feedback loop to our gut-brain connection. So what else? Oh, artificial sweetener, sugar, alcohols. Some of these are high FODMAP, some of these are not high FODMAP. However, they are gut irritants, so it can cause symptoms. Now, I talked a little bit about this one before you joined, talked about fiber. And in general, our message is eat more plant-based fiber, eat more variety. But recently in our program, 2 of our clients were on the other end of things. Most Americans, only about 10% of Americans eat enough fiber. So our message as a whole in the public health space, in the dietitian space is eat more fiber, get more variety. But recently, we are seeing some patients are on the other extreme, on the other end of the spectrum, right? So one of them who has overflow diarrhea, who when she exercises, she has accidents, like she has a fecal incontinence when she exercises, or sometimes when she's not even moving. But what her problem is that she actually have overflow diarrhea that is caused by significant constipation. And when there is a blockage, and when your body needs to go to the bathroom and there's stimulation, the softer stool or the liquid stool kind of sips around the blockage and it leaks out. So, and that's something we actually ask her a lot. It's like, when you have these accidents, what other symptoms do you have? She doesn't have any symptoms at all. The sippage just happens. Now, this is very common for overflow diarrhea, but not everybody with overflow diarrhea reacts like that. Sometimes we see people have, multiple smaller bowel movements. But again, these are things that we really want to understand to see what may be causing your symptoms. And for her case, And because she has IBS, because she has gut symptoms, she's changed her diet to more plant-based, to incorporating a lot of fiber. And when she came to us, she was eating more than double what the recommended fiber intake was. And she, of course, is complaining of overflow diarrhea, which she didn't know she had overflow diarrhea. She and her provider didn't realize that was the problem. And she was complaining of bloating, pain as well. She was in the hospital. Actually, she had so much pain. She had a colonoscopy, and after the colonoscopy, she had a lot of pain that triggered her to go to the ER, thinking something really wrong has happened. Which, if you do have extreme pain, right, you should go to the ER just in case something else have happened. Thankfully for her, nothing was really wrong. They just sent her home again, and told her to check in with her GI again. And her GI kind of just told her to follow the low FODMAP diet and to eat more fiber. I can't remember what the recommendation was.
Yeah.
But it wasn't really helping with her case. And with her case, so the first thing we did is to ask her more questions, right? Understand why she has those sippages, what type of diarrhea it is, and then figure out the plan to move forward. And we actually had her do a clean out to see how it changes her symptoms. And clean out using over-the-counter laxative is very safe. And her symptoms was fabulous after the clean out. She felt so much better. And then we also had her remove some foods as well. It's not on top of the FODMAPs. I don't think she's doing full-blown low FODMAPs. She's doing a gentle FODMAP diet, which is always very helpful, not to do the full-blown low FODMAP diet when you don't have to. But we had her cut out other foods too, and because we think that she might have certain triggers. That's not the FODMAP group. And once she cut those out, her symptoms got really good. And she did a food challenge in December. I think early December before Christmas, and we identified trigger number 1. I think we are doing a second challenge to see if she has trigger number 2. And after that, we're going to have her do the FODMAP challenge group by group. I don't have my FODMAP list here. I know you have it somewhere, but we have people do 12 different FODMAP groups and subgroups and combination groups to see what their tolerance level is so that they can add back the FODMAP foods safely. But oftentimes, I will say most people who work through our program coming to us being extremely low FODMAP and really worried about FODMAPs, after we resolve whatever root cause is causing those symptoms, I hate to use the word root cause, but the underlying cause of what is causing their symptoms, their tolerance to FODMAP will improve drastically. Like, for example, this client that I'm talking about, her name is actually Amy. She's lovely. We have a couple Amy's in our program, but she is really, really lovely, and she's following everything we're telling her to do, and she's doing so much better. But for her, the underlying cause is motility change, leading to significant constipation, leading to blockage in her rectum, causing her to have stool seepage or diarrhea accidents that she couldn't even control, so incontinence. And we identified the trigger already. We think she probably has non-celiac wheat sensitivity, and if she eats anything that contains wheat or gluten, she has extreme slow motility. Things just don't empty properly, and when it's not emptying properly, she becomes very backed up. But her constipation is manifesting as diarrhea. I know, it's mind-blowing. IBS is very complicated. You actually have to, I feel like a lot of these cases, the GI misses the diagnosis and they're like, oh, you have diarrhea? Okay, take Imodium. But cases like this, which we see a lot of, Imodium makes it a lot worse because you're not going to the bathroom. But anyways, this is something we see quite often in the clinic, but this is one type that we see. But for her, I think now that we've identified her triggers, non-celiac wheat sensitivity, the next step is, challenging all the FODMAPs, one group at a time, to see what her tolerance levels are, because she was recommended the low FODMAP diet, and the low FODMAP diet has helped her manage her symptoms, but we don't think the FODMAPs are actually causing most of her symptoms. We do think non-celiac wheat sensitivity plus the backup and the blockage in her rectum and colon was majority of what was causing her symptoms. Okay, so how did I get here? What were we talking about? Oh, food triggers.
Fiber. Too much, too
Food triggers
good
and
thing.
fiber. Yeah. Yes. And we actually have another clients right now. I think a lot of the times our clients don't eat enough fiber, but we have two clients in a row now that are eating way more fiber. And this client eats 3 times the recommended amounts of fiber intake because he thinks,
It was actually 4 or 5 times the RDA in the
okay,
summer. And then he went down to 3 times RDA.
okay, yeah. So I think also, beware of some of the messaging you hear on social media. More is not always better. There is a sweet spots, right, of fiber intake for everybody. Fiber
Mhm.
is extremely helpful. We do recommend, eating the rainbow, getting enough fiber on a day-to-day basis if you can, but you don't have to go more is better. And if you use a fiber supplement, add it slowly. If you have a very sensitive gut, we often tell people, hey, start with half a scoop and see how you do. And then, or half a dose and then increase it gradually. For people
Mhm.
with IBS, we don't want to make drastic changes, but we also don't want to make multiple changes at one time. We want to do one thing at a time and see how you respond, and then decide what our next step will be. Fiber is something that we recommend routinely. We most of the time recommend psyllium husk, which you probably have heard a million times, but oftentimes, people will tell us, I've tried that before, it didn't work for me, or I tried that before, it made me extremely bloated. Now, here's the thing, you gotta start very small and then slowly increase. Don't overwhelm your system. Our system is used to routine. Our gut likes routine. If you shock it, it can go the other way, right? Brooke has this traffic jam theory. You want to talk about that? I love that.
Yeah, so when you have a backed up gut, um, it's like having a traffic jam. You don't want to add cars to a traffic jam. It's going to make it worse, just like you don't want to add fiber to an already backed up gut. So, getting rid of the traffic jam and then slowly adding fiber bit by bit to not overwhelm your gut for sure.
Yeah. And what we usually recommend is maybe about 3 to 5 grams of fiber every few days
Mhm.
when you're increasing fiber intake. So you don't overwhelm your system. And remember, anytime you increase fibrous foods, you gotta stay hydrated, right? Because the fiber will soak up the water. If there's not enough water in there, they might turn into like a really hard
Cement.
blob. Yeah, cement. It can make your constipation even worse if you have constipation. Now, for those people who have diarrhea, psyllium husk can also help. And the way fiber helps is by soaking up some of the fluid and making your stew form better so you don't get, so it improves the stew form.
Mhm.
And it works very well, but start small. And if you don't tolerate a product that have other additives, you can just buy a product that is purely psyllium husk. I do myself, I really like Metamucil. I think it's affordable, it's accessible, it's pretty well tolerated for the most part. But if you have a very sensitive gut, you can try a different brand as well. Okay. What else do we want to talk about? Ha! I think
Uh,
pain is another one. Oh, and if you guys have any questions, you can drop down in the comments. We will get back to them. I think we had some questions earlier on. I don't know if I can find them now. Oh, somebody asked, is there a difference between IBS and ulcerative colitis? Absolutely. Ulcerative colitis is one type of IBD. It's an inflammatory bowel disease. So when people do all the gut tests, right, blood tests, stool tests, scopes, your doctor is trying to rule out celiac disease, inflammatory bowel disease. So inflammatory bowel disease, there's actual structural damage in your guts. There's inflammation, there's structural damage. Oftentimes IBD is managed with diet and medication. Diets alone don't always manage IBD, and it's not, you have to see how you respond and then work with your provider to decide
mhm.
what is going on. And one thing we see a lot in our clinic is not ulcerative colitis. We have clients who have UCs, But microscopic colitis is a form of IBD that we see a lot, and there's a lot of overlap symptoms with IBS and IBD, and oftentimes there are food triggers in these groups, and we have to identify the food triggers so that you're not consuming things that can trigger your symptoms. And we talked about that earlier already. For those people who are just joining, I will post the replay to this video so that you can watch it. Okay, do we want to talk about pain? I think that might be sometimes something we hear a lot, and there's a lot of confusion.
Yeah, so it might be a bit counterintuitive, but if you have IBS and pain, that does not mean that there is damage being done to your intestine, which is the kind of upside of IBS. There's no long-term damage done, at least to your gut. Maybe mentally that can be a different story, but there's no damage to your gut, which is a good thing, but it doesn't necessarily make you feel better if your stomach is cramping up in knots and spasming, which kind of leads to IBS. There is evidence that people with IBS have more nerve endings in their gut, so an increased visceral hypersensitivity. So I think I can't remember where it was, if it was here or your gut is sending messages to your brain. A person without IBS would maybe their brain would disregard those pain messages, and a person with IBS, their brain is like, oh my god, and freaking out, where a person that doesn't have visceral hypersensitivity doesn't even register those pain signals. So I thought that was a good explanation of the pain cycle. And that the pain also doesn't have to necessarily correlate with what you ate. The timing of digestion doesn't necessarily, you can't eat something. You could be in pain from something you ate way earlier than what you just ate. So that is another confusing thing, that it can really take a trained dietitian to help kind of sort through what's going on in your GI tract.
Oh, I kind of want to build on top of that a little bit. Some people eat their triggers. They may not have pain until 2 days later, right? There's a delayed reaction sometimes, and if you are having an immediate reaction, it's more likely FODMAPs, but it's not always just FODMAPs, right? Or sometimes if you're eating things that have the fiber roughages, like very difficult to digest fibers that can rub your gut the wrong way and cause pain. But I like what you said, pain doesn't always correlate to what we are eating. It can be your gut-brain interaction being, messed up, or you have hypersensitivity causing your guts to send pain signals constantly to your brain, which is why we also call IBS the disorder of the gut-brain interaction these days. However, we do see a lot of food intolerances in IBS as well, so I don't fully think that is completely gut-brain. But if you do think your brain and your guts are not working together, having a GI psychologist on your team is very helpful. Oh, let me pull out our patient's guide. Because I think more people need to be aware is that your healthcare team for IBS consists of a full team of people. Usually you will have a GP or a GI gastroenterologist, a GI dietitian, a GI psychologist, sometimes a pelvic floor therapist if there is pelvic floor dysfunction, which is very common in IBS, right? To support you. Now, having a GI psychologist can be very helpful if you are somebody who experiences a lot of pain, and if your anxiety level is very high. What they do is they help you create tools. Basically, like what we do, we create tools around diet and lifestyle or timing, meal timing and hydration. They create psychological tools with you to help you better manage, when symptoms flares. What do you do? So instead of going to fight or flight mode, you retreat and work on yourself to calm things down. One of the things we like to recommend our patients to do, this is more of a general recommendation, is do some deep diaphragmatic breathing. I actually talk about that in our free IBS Relief Masterclass extensively, how to do it properly. You have to breathe really deep into your belly where your diaphragm pulls down and your belly actually extrudes out a little bit. You don't have to do a lot of those breaths, but just a few breaths, like 1 or 2 minutes, you are going to feel a lot better because it calms the gut-brain axis. It turns on the parasympathetic nervous system, the calm system, to help you, regulate the disconnection between the gut-brain axis. Pain. Okay. Before we jump into why pain can persist even after eliminating food, I want to talk also about different types of pain, right? We see so many different types of pain in patients because patients have different underlying causes to their IBS. We see a lot of sharp pain. We see a lot of dull pain. We see a lot of cramping. And that can happen. Cramping can happen before or after a bowel movement. A lot of the times what we see in IBS-C patients is they get cramping after a bowel movement or before and after a bowel movement, which is quite interesting. You would think when you're more empty, you would not have the cramping, but sometimes it can happen, but eventually it will go away as your bowels learn to have full evacuations every day. And then sharp pain can be due to many things. Sometimes with food triggers, it can trigger sharp pain. Sometimes if you eat something that have roughages, so difficult to digest fibers, that can also trigger sharp pain. And then sometimes people have dull pain. Dull pain, usually we see that when a patient is full of stool. If you're carrying a huge amount of stool in your colon, if your colon is stretched out all the time, then you can experience dull pain, like consistently. Oh, another thing that can cause sharp pain is gas. Trapped gas can cause a lot of sharp pain as well. Mm-hmm. So do the deep diaphragmatic breathing or maybe do some bowel massages. I have a lot of that on my profile, so you can look and see which type we recommend. Like help the gas come out. Once it comes out, you feel better. But ultimately, if you have a backed up, if you have stool burden in your colon, you do want to clean it out to prevent it from happening again. So again, that could be your trigger, right? Okay, why pain persists even after eliminating food? I think I kind of explains that, right? Because it may not be from the food. It could be from the stool burden. It could be from the gut hypersensitivity. It could be, a normal reaction of needing to go to the bathroom when your colon starts contracting. And because we have the hypersensitivity, we feel the pain more intensely as somebody with IBS. And I would say I am somebody with IBS. Sometimes I get those contractions as well. And it can be painful, but, take a step back. Don't go into fight and flight mode. Do a few deep breathing, calm yourself down. Sometimes the pain will go away. So gentle gut desensitization. Okay. All right. What else? Do we want to talk a little bit about SIBO, small intestine bacteria overgrowth? We are seeing that a lot in our clinic, and oftentimes there's conflicting messages. There's a lot of questions about SIBO. Maybe we should. How long is our life already? Is it getting too long? Do anybody have any questions? Oh, there is.
Yeah.
Oh, you want to read it?
Can the method of cooking help with trigger foods like soaking/cooking high fiber foods to reduce the risk of symptoms?
Absolutely. Yeah. We do recommend, if you have a very sensitive gut, cooking off your vegetables and maybe peeling the skin of certain fruits and vegetables before consuming them, because those can be very tough fibers that we may not break down. And beans, I recommend beans even on the low FODMAP diets, right? I'll give you an example. For beans, you have to soak it. You can boil it and soak it, but you have to soak it for a long time for the FODMAPs to leach out of the beans. Or sometimes you can, maybe sprout it and then remove the outer skin. The FODMAPs are on the outer layer of the beans. So, or you can use canned beans and pour away the liquid and then rinse it. Now, the reason is, like I said, the FODMAPs are on the outer layer of the bean. So by soaking, some of the FODMAPs will get out to the liquid, and you don't want to drink that liquid, and you don't want to cook with that liquid. So you want to get rid of it and then rinse it and then cook. So there are ways to lower the FODMAP contents. There are ways to soften the fiber a bit more, but cooking and removing the skin are probably the best ways if you have a very sensitive gut. But again, usually once you address what the underlying causes are to your gut, you can probably tolerate more of these foods without symptoms. So don't just focus on cutting out food. All right, let's talk about SIBO real quick because we have a lot of questions. People always ask, should I take antimicrobial? Should I take probiotics for SIBO? And the answer is, it depends, but most likely no, because those things are not evidence-based. But what SIBO is small intestine bacteria overgrowth. And what it means is small intestine is mostly sterile. It's not completely sterile because food passes through, right? And that's how we deliver, your probiotics to your large intestine. Food does pass through the small intestine, but sometimes too much microbes stay in the small intestine, causing you to have more symptoms. And you will hear a lot of the messaging online is you have to eradicate SIBO. You have to test, eradicate, and the way to eradicate it is by antibiotics, or sometimes you will hear people recommend supplements to eradicate SIBO. Do they work? They do work in eradicating, but they don't work in a sense that if something is wrong with your motility that causes more food or more bacteria or more microbes to stay in the small intestine, SIBO will come back again. So eradication is not the only thing you need to do for SIBO. You really need to understand what is going on, why it is happening. Let me share, maybe an example. One of our past clients who works in surgery, she's a healthcare provider. She works in surgery, so she has really busy schedule. She came to us with SIBO and IBS, and she had done 3 rounds of antibiotics for her SIBO. The first time, it took care of the SIBO. She felt great, no more bloating, no more urgency. So she came to us for diarrhea. But this is an interesting case study. I think you'll find it interesting too. Well, I hope you find it interesting too. And drop your questions in the chat. So she came to us for diarrhea, for bloating, and just a lot of urgency. It made it difficult for her to live her life, go out, or even go to work. Again, she works in surgery, so it's very intense. And what she ended up doing is not eating anything before she goes into work, and she would eat everything at night because she doesn't trust her body to not run to the bathroom when she's in surgery, and she can't run to the bathroom when she's in surgery, and she was really afraid of eating. So she did 1 round of antibiotics to treat the SIBO. She was perfectly fine after that, but soon after that, SIBO recurred again. She has those upper GI bloating, a lot of belching, and she did another round of antibiotics, and the doctor was like, maybe we should try something else as well. Why don't you go try the low FODMAP diet and see if that helps you? And did it help her? I think it helped her a little bit with the bloating, but it really didn't help her in the sense of, stopping her SIBO from coming back. And then when she finally did her 3rd round of antibiotics, she was like, I need to find somebody else to work with me on this diet thing because I'm not eating enough. I'm really afraid of food. I can't live my life normally. So she came to us, and when I did like a thorough inspection of what's going on with her day and how she's eating, I was telling her, I think, well, she had her SIBO treated, and then she went back to her baseline, and her baseline was actually constipation. We looked at her stool, looked at how her diet habit was. She wasn't eating enough fiber, because she was on the low FODMAP diet, right? When you're removing a lot of fermentable food, you're also removing a lot of dietary fiber. But she reverted back to constipation. And she was actually more constipated than she knows. That constipation leads to slower gut motility. And when there is slower gut motility, it leads to having SIBO recurrence, right? If they're specked up, you're more likely to get SIBO because the bacteria that's supposed to just pass through now is staying in the small intestine, okay? And when we figured it out, what we really worked on is make sure she has a full evacuation every single day. We did And what else? We also worked on lifestyle challenges to help her create a routine that works for her. Again, she works in surgery. She doesn't have time. And she really needs a step-by-step routine. And what we did with her is, wake up maybe slightly earlier before you go into surgery so we can have a good breakfast, have protected potty time to go to the bathroom, right? So every day, go to the bathroom, have full evacuations, and then she go into work. Because when she goes into work, she has to be in surgery for maybe 5 to 7 hours. She can just run to the bathroom quickly. She can't do much more than that. But we've taken care of the full evacuations prior to going into work. And once she had that routine down and full evacuations every day, SIBO never came back. And she didn't do a FODMAP reintroduction because she's so busy. She just ate all the foods again. And at our last consult, she told me, Jessie, I had tacos. I had street tacos with raw onions on top, and I did not have any symptoms. My SIBO is gone. I'm eating everything I can again. I can live my life normally again. And she was really, really happy. She doesn't have to take Imodium, stay on the low FODMAP diet, and hoping things will stay that way. And treating SIBO again and again and again, because we know the antibiotics for treating SIBO is really expensive. And again, it doesn't treat the underlying cause to why you have SIBO. So we see people having SIBO again and again and again. Now, in our clinic, slower gut motility is one of the big reasons why people have recurrent SIBO. But there are so many reasons to why somebody has slower gut motility. This particular client, who is a healthcare provider, her problem was she wasn't drinking enough fluids because of her work. She wasn't eating enough fiber. She didn't have a bowel routine in the morning so that she can go to the bathroom. So we really focused on, getting enough hydration in, having her eat enough fiber throughout the day. And by the end, she's very smart. She said, Jessie, I make this soup that has so much vegetable in it. I eat a portion of it every day, or I eat, 2 portions of it every day. I make sure I go to the bathroom every day. So she was fully evacuating, and her SIBO never came back. So don't just focus on restricting food, because a lot of the times when you just restrict your food, it can affect your motility even more. It can make your symptom even more. And worse yet, so especially the low FODMAP diet, is when you are restricting fermentable carbohydrates, it can change your gut microbiome. It can cause the microbes that can help you break down FODMAPs to decrease in volume. And these are the good gut microbes for our guts. Now, we don't fully understand what good is because everybody is different, but we know FODMAP feeds lactobacillus. FODMAP feeds types that we think having more of them can be helpful for protecting our gut lining and the integrity of our gut lining. So don't just cut out food. And the low FODMAP diet, I think we should do maybe a webinar or maybe like a IG Live next week on the low FODMAP diet, a little deep dive on it, so that especially in the beginning of the year, people are jumping on diets, people are jumping on different things, but you need the information to talk more about. But that's something, I want to get it out there. Don't just stay on low FODMAP. Low FODMAP is only recommended for 2 to 6 weeks. And most of the people we work with, they're not on a strict low FODMAP diet because it's not necessary. The goal is to bring your symptom down to baseline. Diet is one way to bring it down, and not everybody needs it. If you do have, if we do suspect somebody having certain food triggers, then we do recommend diets, but it's not always the low FODMAP diet. Like we talked about earlier, there are at least 9 different food triggers that we are looking at when we look at our patients' bowel movements and what they're eating and what their symptoms are. So it's not always FODMAPs. Okay, shall we do some Q&A? I think I talked a lot. Yeah, okay, I have this one here. I'm getting hemorrhoids often nowadays. I used to drink alcohol and I stopped now because of persistent bleeding. Good for you. Alcohol is a gut irritant. We do recommend people to limit it if they can't eliminate it completely. I mean, we don't want to take the joy out of people's life, but you don't always need to rely on alcohol to have joy, right? So that's something to think about as well. And alcohol is a gut irritant, so I'm glad you were able to cut it out. And somebody was asked, did I missed it? Did she require the second round of antibiotics? She did before she worked with us. She was on her third round of antibiotics when she finally said she was fed up and be like, I need somebody else to look at my case and come up with a plan or help me with my eating as well, because her doctor told her to go on low FODMAP. And we all know low FODMAP is extremely restrictive. And yeah, so she did 3 rounds of antibiotics, and we finally worked together. What we really worked on is improving her gut motility so that SIBO did not come back, and really creating a plan for her. Now, everybody is different. I would say a lot of the cases we work with, the motility change comes from having a food trigger. People have a food trigger that when they consume it, it changes their gut motility, it slows down their gut significantly, causing them to have recurrent SIBO. And sometimes these type of food trigger activities symptoms are very similar to SIBO as well. It's oftentimes it's middle to upper bloating and distension, and sometimes even pain. So we do a lot of cases like this. We do have to ask more questions, like, are you belching a lot? How, what else do we ask? Have you done a breath test? We do look at breath test results. We don't order them. We work with our patient's provider to get the breath tests if needed, but we don't usually recommend it at the beginning of working together because we want to assess symptoms first. We want to work on improving motility first to see if that changes the symptoms, or we work on, maybe removing certain food triggers first to see if that changes the symptom. Because if that changes the symptoms, then we don't need to, then it's probably not SIBO. SIBO is interesting because there were research that said 70% of IBS patients have SIBO. That's not true. I think newer research says somewhere closer to 30%.
I think too, it's important to note that if you have SIBO, you do need the antibiotics to treat it, but the diet can help prevent it from coming back. So diet alone does not treat the SIBO.
Right. Yes.
Yeah.
This is a really good question. When would probiotics be indicated for IBS or SIBO? Very good question. So probiotics is not indicated for SIBO at all. Oftentimes, it's actually one reason why people have SIBO. It increases people's risk factor of having SIBO. Now, when it comes to IBS, though, it's tricky because I still don't feel like the research is fully there. The AGA, American Gastroenterological Association do not recommend probiotics for IBS. Do we use it? Sometimes we do use it, but it really is case by case. It depends on a person's symptoms. What symptoms are we treating? Are we talking about bloating? Are we talking about pain? Are we talking about constipation? And then we do put patients on a very short course of probiotics if we think it is helpful for them when we match the right strain with the right symptoms that we are targeting. One of our past clients who is a healthcare provider herself, she came to us for IBS diarrhea, right? So she actually went to a different dietitian in the past before coming to work with us. And that dietitian put her on a probiotics. That has evidence for IBS, but it only has evidence for IBS constipation. And these patients have IBS diarrhea. And guess what? The probiotics made her IBS a lot worse. So in our clinic, we are very conservative. We don't use a lot of probiotics. There's only two brands and 2 strains that we ever recommend. And we only recommend these 2 because we know it works well for certain population, for certain subtype. But a lot of the times we don't recommend even anything.
And
so
most clients come on a probiotic, and first appointment is usually Jesse or I saying, and stop that probiotic. I don't think we've ever said continue that probiotic.
No, we never say that. And sometimes, and I think a lot of what we see is patients who went to their GI or went to multiple GI, they don't get a relief or diet or a proper, treatment plan. They get really frustrated, and then they go the alternative routes. They go to a functional doctor, or they go to a naturopath, and then they were put on a ton of supplements, and usually there's at least 1 probiotics in it, and if not, other things to try to manage the symptoms. And of course it doesn't work because no, you don't need all those herbal supplements that we have no idea what's in them. They're unregulated. And oftentimes they have high FODMAP ingredients that make the patient's symptoms even worse, right? And one of our new clients, that is exactly her story. And with the first appointment with me, I was like, let's stop off this. Are you okay with discontinuing like this $500 of supplements that you've purchased from this other provider? And she was like, yes, I'll listen to you, whatever you tell me. And she stopped and she's actually feeling better. Then the second thing we do usually in our first appointment is give them a list of labs that we want to see. And usually they bring it to their provider, their doctor, and their doctor orders it for them. So that's how it usually goes. And then we assess the lab when it comes back. And these are labs usually a nutrient status, maybe a proper celiac screening if they've not done celiac screening properly in the past. But, if you are taking a lot of supplements, what we want to tell you is that, don't waste your money on supplements. Do we recommend supplements on our program? We do, like we talked about. Sometimes we recommend that to eat one of the two type of the probiotics we use. We recommend a lot of fiber. We usually start with, what is it? Psyllium husk. I talked about this earlier. Sorry, my brain is getting late in the day. Psyllium husk, that's pretty much all we ever recommend, and our patients have really good results because supplements is not going to buy you IBS freedom. It might free up space in your wallet. I think that's what it really is. Yes. Can some of them help with some symptom management? Potentially, but it really doesn't get down to what is really going on in your guts, right? Okay, we have some questions here. How do fermentable foods affect these population, like kimchi and yogurt? Good question. I think, with IBS, small amounts is tolerated, but if you do have SIBO, small intestine bacteria overgrowth, it can make your symptom worse. So treat the SIBO first before adding back fermented foods. And that's something we actually recommend a lot because everybody likes to eat yogurts. And we love yogurt too. It's really good for our guts. Kimchi is really good for our guts. But when you have too much bacteria overgrowth in the small intestine, that can make your gut symptom worse, especially in the middle part inside the small intestine. And these symptoms can be gurgling and gushing, and maybe you're belching a lot, and maybe you have diarrhea. So it really depends person to person. If a patient can tolerate it, we usually recommend it, encourage it. And we usually recommend things that are less processed and that have less additives to them for better toleration. Phage yogurt is something that we really like. What else? So the chobani with nothing. Don't get zero. Don't get stuff that have like a bunch of additives, right? Take a look. And nowadays, the yogurts sometimes have fiber added to them. And to me, as a GI dietitian, I'm just like, why? It already has some good benefits, pair a yogurt, a plain yogurt, with a fruit. There's your fiber. Don't buy a yogurt with fiber added. Most of the time, they add high FODMAP fibers in it. Inulin, chicory roots, those are the things that's added. And these are very high FODMAP. They're fructans, and it can cause a lot more symptoms. Okay. And somebody said, I love congee as probiotics. Congees are not probiotics. Congees are... So congee, if we have the same understanding of what congee is a Chinese food where we cook the rice into soupy consistency. It's not a probiotics. It's a food. It's a carbohydrate source. Sorry, but yes, congee is not a probiotics. But in Chinese culture,
it's fermented. Congee itself isn't inherently probiotic, but it becomes probiotic rich when fermented or served with fermented toppings like kimchi.
I've never heard fermented congee. Okay.
Yeah, you'd have to ferment.
But congee is just porridge. That's from rice. Yeah,
if you're fermenting it, I guess.
No, you don't ferment congee. You throw it away when it goes bad. But that's me. I'm from Hong Kong, so maybe the way I eat it is different. Yeah, no, we make congee a lot when we're sick. And actually, I made congee recently because my kid got food poisoned. Oh, poor thing. She's fine now. She's fine now. Thank you for all of you who sent a message. I really appreciate it. But for a few days, it was like when you have a sick kid at home, it's just, a lot more work. But we know she was okay. We did go to the doctors and get her stool tested. I got
So
the proper result today. Yeah.
there's the congee that's Bengali style. You
Oh.
try a Bengali style. I'm butchering these next two words. Pata bahat, by fermented cooked rice overnight before serving.
Oh.
It's
So is this an Indian way of eating congee? Okay. We learned something new. I'm gonna ask my friends and see if they do that. Is it penna that? Or so there are different types. Okay, so you
Yeah.
ferment it and then
Yeah.
interesting. The person responded here, Tamil style, Tamil.
Interesting.
I'm sorry if I'm saying it wrong. I'm so sorry. Okay.
Well, we just learned something today.
Yeah. Okay. Tamil Nadu, India. Okay, different type of congee. Interesting.
I've
Very
never
cool.
heard it before.
Okay, but it's also boiled rice, but you kind of
Yeah.
ferment it before serving. Okay. We've got a different question here about fiber intake, grind or whole chai?
Chia.
Oh, chia.
I personally like the uh ground or milled chia versus I can't drink those whole seeds down.
Okay. Uh-huh.
But
I
it's
like
probably easier
the
to digest too.
yeah, I think ground is easier to digest and you probably get more nutrient benefits out of it because it's, the omega-3 is inside the seeds, right? If you're passing the seed, you're not getting the omega-3 or omega-6. I don't know fully what's in there, but
Yeah.
I actually really like the pudding because
Mm.
in Hong Kong we have we have a lot of cold desserts with some kind of ball in there. Chia is not a traditional one, but we could replace chia and we can use chia instead of something that is like the tapioca balls. But you have to
Yeah.
make sure it is well soaked in water before you consume it. Don't consume any dry chia because it can soak up all of your digestive fluids in your
Yes.
gut and it can turn into a concrete. So make sure you soak it very well before you take it. I think that goes to the ground up ones too, right? Make sure you are drinking a lot of fluids with any sort of chia.
Yeah, it doesn't
Yeah.
soak the liquid as much for sure, but I alternate ground flax and ground chia.
Okay.
To give
Yeah.
a little, yeah.
Give it a try. But like we said earlier, one our favorite type of fiber for IBS patients is psyllium husk. So, try different ones and see what you tolerate better.
Mm-hmm.
And start with a very small dose, add a lot of fluids in. Okay. Yes, and we've got somebody saying chia pudding is delicious. Yes, it's delicious. I like it. I don't make it enough. I probably should. Yeah.
Yeah.
Okay, I think we've talked a lot today about IBS triggers. If you are just joining us later, go back to watch the whole thing. We talked about food triggers, non-food triggers, and what else? Oh, and SIBO and fiber. Fiber is something, we want to really increase awareness on both ends, right? Too much or too little. And some clinical things that we see a lot of that can be helpful for you. Again, this kind of videos are educational only. It is for you to have better knowledge about your IBS so that you can have better conversations with your provider and come up with a treatment plan. Now, for those of you, if you want to work with us, send me a DM with just the word group or comment on this video, say group, GROUP. I'll send you 3 links about working with us. The first link is our group program link. We have, I think, 3 spots left. I can't remember clearly, but we've already onboarded a lot of new patients who want to work with us. Our program is about 3 to 4 months long, and we meet every single week. And with IBS, because everybody's IBS is so different, it really requires us, looking at what you're eating, what your symptoms are, what your bowel movement looks like, and give you suggestions every week to help you get better faster. Which is why, if you've worked with a dietitian before, if you've seen them, you know, every 6 months, that's really not going to get you anywhere. And we find that it just adds the frustration for both ends, like the provider and also the patients. And we are constantly, you know, even with our patients, right, we are constantly communicating. Twice a week, we are responding to questions. We are commenting on their journal, be like, do you think this triggered your symptoms? You know, do you think the diarrhea you have today is because of something you ate yesterday or something you ate 2 days before? We're constantly looking for the trend and understanding what is going on, and then teach our patients like, hey, this is what we are seeing. And then we do food challenges to confirm our suspicion. Yeah. So if you want to work with us, we have a few more spots left. You know, if you don't want to work with us, it's okay. I do recommend everybody to watch our free IBS Relief Masterclass to learn more about IBS. We have more graphic images about different types of diarrhea and different types, you know, of gut-brain interaction things that you can do to help improve your IBS. For those that want to watch the masterclass, comment class, or you can just comment group and get all 3 links. So link 1 is our program link, link 2 is our free masterclass link, link 3 is actually booking a call with me to see if the program is a good fit for you. All right, everybody, thank you so much. We'll do this again, and we really appreciate your participation and you spending your time with us. I hope this is helpful for you. All right, and thank you, Brooke.
Bye.
Bye.